New Zealand.
Some big players, they're electric going forward.
World football at the Women's World Cup from the BBC World Service. Find it wherever you get your BBC podcasts.
Welcome to The Inquiry. I'm Charmaine Cozier. Each week, one question, 4 expert witnesses and an answer. June 2023. Before becoming British Prime Minister, Rishi Sunak was responsible for controlling public spending as Chancellor. So at first glance, a government statement appears to clash with that because it wants tens of thousands of people to lose pounds. A few sentences later, a PM quote makes things clearer. Announcing a £40 million pilot scheme to increase access to specialist weight management services in England, it reads, "Using the latest drugs to support people to lose weight will be a game changer." International demand has already skyrocketed for one of those game-changing prescription drugs. Stories of substantial weight reduction lit up social media. Rumours are rife about who might be using it in Hollywood. But it's not meant for everyone. So this week we're asking, are weight loss drugs the answer to obesity?
Part 1. A worldwide problem.
So Ozempic is a very trendy drug these days.
Dr. Disha Narang is an endocrinologist and director of obesity medicine at Northwestern Wake Forest Hospital in the US state of Illinois.
It was specifically introduced into the medical world as a medication to improve type 2 diabetes, and it is in the category of medications called GLP-1 agonists. So GLP-1 is a hormone in our body, and GLP-1 agonist is the medication that's delivered. And so you're basically enhancing the hormone function, you're introducing that into your body.
It regulates blood sugars, which increases insulin sensitivity. That enables people living with diabetes to reduce their injections and pills, but that's not all it does.
Ozempic has certainly taken increased popularity in the last year or two due to its weight loss benefits. It's not necessarily news to the medical community who's been using this for all these years in our patients with type 2 diabetes. However, it certainly has taken an entire popularity of its own given the weight loss benefits.
And that happens in a couple of ways. By slowing down the way the stomach empties, it speeds up that feeling of fullness.
Another way that it works is that it works at the appetite center of our brain, and it helps to suppress our hunger hormones. And so what patients will often say is that, yes, not only are their blood sugars well controlled, but that mental chatter about various food cravings and hunger really cuts back. And that's the biggest difference people have seen when they've been on the medication.
Ozempic and Wegovy, which is in the English pilot scheme, have a lot in common.
Wegovy and Ozempic are the exact same medication. The medication is semaglutide. Semaglutide, as Ozempic, is approved for patients with type 2 diabetes, and semaglutide is approved as Wegovy for weight management. But it's the exact same medication.
So, same drug, different brand names. Semaglutide also aims to stop lost weight returning.
And that's why this has become so valuable in the chronic treatment of obesity, because this isn't necessarily a medication to help somebody lose 5 or 10 pounds temporarily to get ready for various events and things like that. But this is a chronic long-term therapy because most people struggling with obesity have struggled with obesity for many, many years.
In 2021, the US Food and Drug Administration approved Wegovy for use as a weight management medication.
Obesity really is a worldwide problem. We are looking at about 150 million people in the US alone by 2030 being in the obese category. It's not a disease of vanity. This is truly a neurohormonal disease that needs long-term medication just like anything else.
In order to qualify for it, US patients must have either a body mass index of at least 27 and be diagnosed with one or more weight-related conditions, including type 2 diabetes, high blood pressure, heart disease, high cholesterol, or sleep apnea. Or a patient can have a BMI of 30 or higher and no other medical condition. However, even those who meet the criteria can miss out because of cost. It has to be injected once a week.
Now, in the US, even beyond that, many insurances will still reject prescriptions for Wegovy or other GLP-1s for weight management. These are expensive medications.
Are we talking hundreds of dollars?
No, we're well above $1,300 for the prescription.
That $1,300 US and above is the price per month, so just 4 injections. But affordability isn't the only issue here. There's also availability, or rather a lack of availability.
There has been an unprecedented demand for these medications in the last year and a half, and a lot of this has been fueled by social media.
It's being driven by some influencers, reality TV stars, and feverish speculation about which celebrities may or may not have used it to transform their appearance. On TikTok, the hashtag Ozempic has more than 1 billion views, with just under 500,000 for videos which tag Wegovy.
It has become highly in demand, but also very much in short supply. What has happened is that our patients with diabetes have not been able to get their medications in a timely manner, and those who are requesting the medication for weight management, we've just had trouble finding it in general. And so only in the last 4 to 6 months has Wegovy been available, but now we're back in a shortage again of certain doses of the Wegovy. So this has been an ongoing issue. And so, we're doing our best to kind of keep up with the demand. And I know that the manufacturers of these medications are trying to keep up with it as well.
Part 2. The medicine makers.
What companies do is a forecast. So they say, okay, I estimate that next year I will sell this many in country A, this many in country B, and then you will plan your manufacturing accordingly. So that usually goes quite well. Sometimes it does go wrong, however, because there can be errors in estimating the planning, of course. I'm Adrian Venhoven. I'm the Director General of Medicines for Europe, which is an industry association representing manufacturers of generic, biosimilar, and value-added medicines. For most medicines, what happens is you have a company that develops a new chemical or biological substance, and they test that substance for, let's say, activity against a disease.
And if that works, then there's more rigorous testing. If that all goes to plan, it's approved by a body like the FDA in the US or the European Medicines Agency.
Usually that new medicine will be protected by a patent, and this will give it a roughly 20-year monopoly on the market, and consequently it can be sold for a relatively high price in order to recoup the investment cost into that medicine. After that more or less 20-year period, there will often be a generic or a biosimilar medicine developed to act the same way against the disease as the original drug.
So what can a manufacturer facing a surprise surge in demand for their products do?
If you have a multi-source medicine like a generic market where many companies are supplying the generic medicine, one company can have a manufacturing problem and therefore it's unable to supply. This is quite common in the pharmaceutical sector. And that means the other manufacturers need to fill the gap. And that can be difficult to do, to suddenly have to fill the gap of your competitor if your competitor has a large market share.
But another situation can arise if a drug is under patent.
This is where a medicine is regulated or approved for one indication, so for example for diabetes, but then doctors realize that it can be used for a different disease, and they can then prescribe that what we call off-label. So it's not written on the label of the medicine, but the doctor can say, okay, it also works in this disease, so I will prescribe it to that patient. And that can also lead to very big increases in demand that were not foreseen.
But rapidly boosting production to meet that demand is tricky.
So it's very, very difficult in this industry for 2 reasons. So each batch of medicines, let's say a batch can be between 50,000 and up to 1 million boxes of medicines, needs to be kind of thoroughly tested as it's being produced to make sure it's meeting all the quality standards. If it does not, that whole batch of medicine basically needs to be thrown away. Well, something can go wrong because you're producing much faster, basically. So that's kind of one major risk.
The second one is staff related.
So you have very, very specialized workers. And if you need to increase the production, well, you cannot just hire a new person off the street and train them in, say, half a day. You need to train them over months and months. So it's quite challenging.
Expiry dates also determine how much of a medication can be stored.
So for solid medicines like pills and capsules, typically they will have a longer shelf life, let's say up to about 3 years. But for many liquid medicines that are injected, they have a much shorter shelf life, more like 1 year maximum. And indeed, it's really not possible to store or stockpile these medicines. What companies do typically is they will store inventories of the ingredients or inputs that you need to manufacture the medicine. That way, if there's a surge in demand, they can basically increase the speed of production by using excess inventories.
When it comes to distribution, that works in various ways.
So it depends really who is the buyer of the medicine. In most cases, it's the one dispensing the medicine to a patient.
That can include hospitals, pharmacies, bulk buying wholesalers, or governments in countries where medicines are subsidised. If a drug is under patent,
the company with that patent will be the one manufacturing the medicine, and they can decide where it goes, and that will normally be allocated to where there's an ability to pay, which is either where there are some very wealthy patients or where the government pays for that. And you see that quite clearly, that the access to medicines is very uneven across the world.
Giving you the lowdown on the Women's World Cup Down Under. World football at the Women's World Cup from the BBC World Service. We're in Australia and New Zealand throughout the tournament, going behind the scenes to bring you all the excitement of the competition.
This is something I've dreamed of. I love the spotlight, I love pressure, I love it all.
Listen now by searching for World Football wherever you get your BBC podcasts.
Part 3. Drugs for Life.
So among the drugs that are approved for weight loss, the oldest that is still on the market today is called phentermine. That was originally approved in the United States by the FDA in 1959 with similar approvals internationally. And that is generally an appetite suppression that's approved currently for short-term use.
Dr. Jenna Trineri is an assistant professor at the Perelman School of Medicine at the University of Pennsylvania. She's also director of clinical services at its Department of Psychiatry Center for Weight and Eating Disorders. Other weight loss drugs are combinations. That means they repurpose medications with other uses but with weight loss effects into a single dose.
One combination is phentermine with topiramate, which is a medication that is in the anti-epileptic category that can sometimes be used to treat conditions for chronic pain, restless leg syndrome, but also produces larger weight loss when the drugs are combined than phentermine alone. Bupropion is most typically used to treat depression, and naltrexone is most typically used to treat addiction, but that combination is approved for weight loss.
Those drugs essentially focus on curbing appetite. However, that's not the only way.
There's one additional medication that's been available previously in pill form called orlistat that works completely differently. It's a fat blocker, as in it actually stops the absorption about a third of ingested fats from the diet, and therefore can help people to actually take in less calories from the foods that they consume. So that is a categorically different kind of medication, and in a lower dose is actually available in some locations over the counter, whereas the rest of these medications are in need of a prescription.
So how different are the newer GLP-1 medications from what's gone before?
So these medications are categorically different in that they interact directly with one of the hormone signals that we know is part of the appetitive system, whereas these other medications that had been approved previously had an appetite reduction effect, but it was more indirect.
Dr. Jenna Trineri says that, on average, she's seeing larger weight loss in clients.
Our center and myself, we provide lifestyle modification treatments, so these individuals are being supported with making healthy changes to their diet and physical activity, which is also how these medications are intended to be prescribed. But despite that, most individuals with lifestyle modification alone are going to lose around 5 kilograms to 10 kilograms. Here, with these weight loss medications added, we are seeing much larger weight losses through, say, 20 kilograms and beyond in some of our patients that just aren't typical of lifestyle modification by itself.
Despite the social media hype wrongly suggesting otherwise, this is not a short-term treatment.
What I hear more commonly is individuals that still believe that after I've taken this and lost the weight, I can stop taking it and I'll be able to maintain the weight loss. And so that's why I always start there when I'm talking to patients, with the idea that these medications are in fact intended to be prescribed in the long term. And it's not that they haven't developed good habits while taking the medication, they very much have. But part of the reason that it's less tempting to deviate from those habits is because of how the medication affects those signaling systems.
So expect long-term repeat prescriptions.
And that's true of all of the medications that are currently on the market today, not just unique to semaglutide. On average, you would see weight regain when people stop taking one of these medications. The idea is similar to what we think of with blood pressure medicines, where someone takes the medication to bring down their blood pressure, but we don't expect them to just take it for a day or two, and then the blood pressure will continue to be resolved if they never take it again.
The latest generation of drugs are not without side effects.
The majority that you'll see with these newer medications, like semaglutide, are going to be gastrointestinal in nature. Typically, the most common side effect is nausea, experienced most generally when people are starting the medication or go up in dose, and some individuals might experience that in a more intensive or more chronic way. That means it's not a good fit for them.
Part 4. Weighing up the future.
The excitement right now in obesity obviously is people realize that this is an important problem. Probably some 20 to 30 years ago, they started working on it. And we have such a long history of failure because nothing really worked, or it also only led to very moderate weight loss in the clinic. So 3 to 4%, nothing dramatic on a year. And now with semaglutide, we see the first time really dramatic changes. And that's why you have this huge excitement despite the many drawbacks of the GLP-1 class. It's definitely a major breakthrough, but it's not the solution to obesity alone. We need much, much more tools to move forward in this very important disease.
Josh Geordie is the CEO of Ericol Therapeutics, a biotech company based in Switzerland.
Science never stops. It's not a marathon. There is no goal. It always continues. And that's part of humankind, right? To get better and better.
The hormone-mimicking GLP-1 class of drugs have been a major breakthrough, but there's room for improvement.
So it's still based on injection. So this constrains, in a way, the number of individuals who are willing to take an injection. It's a very different subject of patients that want to inject themselves once a week.
So a future goal is for a range of weight loss approved drugs with the same effect, but which can be taken as a tablet. That's proved elusive so far because of chemical structures.
So semaglutide, if you would just apply it like this, would get broken down in your stomach and small intestine, and obviously then cannot have a pharmaceutical impact.
So it would be destroyed before it had a chance to reach the bloodstream. But remember, science never stops.
And if you look at other chronic diseases that are much better managed in the clinics today, one sees that they are treated by once oral formulations. And I personally would think that this is also going to happen in obesity or in body weight control.
As to when or where that might happen, discovering and developing new drugs is a complicated, expensive and long process.
On average, it takes, I think, 7 to 10 years to get a drug to market. But the chances for success are extremely small. So normally people start with, hundreds of programs and they hope to get one to market. And that makes the whole development and prediction when the next breakthrough comes very difficult. It might be just around the corner, or it might take another 10, 20, 30 years.
It's an experience Josh Geordie's company is familiar with.
We're developing what people call the next generation anti-obesity drug.
It's working on an appetite suppressor that can be taken orally.
And this new drug obviously builds on all the knowledge of the failure in anti-obesity drug development. So we're looking to not have the side effect profiles such as gastric emptying, which induces nausea. We're looking for higher compliance based on the oral formulation. And so we're in a way, as a company, taking all the learnings of the available drug development and research programs and putting them together in a program which has a chance to finding something that is better.
Semaglutide, which is behind the Wegovy and Ozempic medications, was developed by the global drug maker Novo Nordisk. It currently leads the field.
But they are obviously not alone. Now you have a race starting, and a very fast follower is obviously Eli Lilly, which have posted some wonderful data on a very similar molecule called tirzepatide, and we expect them to go to market in the next half year. So they have already fierce competition on the Wegovy brand, expecting coming up in the next half year or so.
Novo's patent for semaglutide is due to expire in 2030. It could try to extend that, which would give it another 5 years.
But what happens thereafter is that they go generic, meaning anybody else can produce the substance and sell it. And this leads to a dramatic price cut. So many people will get access to the drug to a lower price. And I think this is something very wonderful in the long run, right? If you think about aspirin, right, it's off patent since many years and still drives a lot of good outcomes for different individuals. So there are major improvements to be done on the patient, but also on the economics.
It's important to note that increased access driven by expired patents and resultant price drops doesn't mean these drugs should be available without prescriptions in the future.
I think that would be terrible development. And the reason is that this is medication that needs to be tightly regulated. It should be only taken, in my opinion, in combination or in treatment or go hand in hand with, being under an MD's control and being somebody who understands what's happening. Particularly because you might come to the Hollywood drug notion that you can use it, to become Mr. Bodybuilder or Miss Teen somewhere. I think that would be very terrible use of a very potent drug.
So, are weight loss drugs the answer to obesity? The root causes behind this chronic condition are as varied as the individuals who live with it. Medication alone is not a silver bullet. It's also a world away from a short-term fix. But in a world where many sections of society are image-obsessed, that message is lost on millions of social media users who want it, but don't need it. This edition of The Inquiry was presented by me, Charmaine Cozier, and produced by Anushka Mutanda Dawati. The research was Bissy Adebayo, editor Tara McDermott, and technical producer Cameron Ward.